theory also goes out the window.
Okay. So Farhana, we are live on Facebook. So, I think we are live on YouTube as well. So good morning, good evening, good afternoon, and good day to everybody. But especially good afternoon to you, Farhana, in Pakistan. Thank you for taking the time to be with us. Farhana, you are for us, the leading figure in TB in children, because you are the chair of the Stop TB Partnership Working Group on Childhood and Adolescent TB. And I want to start with you, and I'm really honored and happy that you took the time to be with us, because we are trying very hard together with our partners to get more attention on TB in children. And yesterday, as everyone saw, we launched a new partnership and a new champion for TB in children, Hello Kitty. And we try to do whatever it can to raise awareness about TB in children. And maybe it's not that much, but we want to have not only the Hello Kitty, the figure, we want to have some interaction with Hello Kitty, but also we want to give the opportunity for global leaders like yourself, also WHO, Global Fund, our partners from the Union, from MSF, to have conversations together. But also we will bring here children with their parents to tell us about their stories with TB. So we will do this very regularly. But we start with you, Farhana, and I will be very happy if you can share for all of us here, for all the people that are not aware, why is TB in children so important? And how come that in 2020 we have big figures, and maybe you tell us a bit of the figures of children with tuberculosis. So Farhana.
Thank you very much, Lucica, for this opportunity to shine a light on this really important problem of tuberculosis in children. Again, I think people often don't know or haven't heard that tuberculosis is very much amongst us still. And children, unfortunately, were somewhat in the shadows up until maybe 10 years ago, when we started ramping up, and we actually started, WHO actually started reporting figures as recently as 2011, which is like, which is really crazy. And however, as you said, that why is it so important? Well, to put it into perspective, the Global TB report, which was very recently came out for 2020, which actually reports 2019 figures, tells us that almost 230,000 children died of tuberculosis in 2019. Now, if you think about it in terms of days, that's like almost 700 children a day, a child every 2 minutes. So as we talk, as this talk progresses, as many as, the 30 children are going to lose their lives, which is crazy in this day and age when the disease is, as we say, preventable. It's not a genetic disease. It's not something that, oh, you're destined to have. This is something we could have prevented, and this is something that we can treat very well. So that, to me, makes it extremely important as a clinician taking care of children. The other thing with children is that compared to adults, younger children are unfortunately very susceptible to not only acquiring infection, but going from infection to active disease. And then when they do so, this can happen very quickly, and they can actually develop really bad forms of it. So, TB meningitis, disseminated TB, sepsis, conditions where as clinicians, we know that we have to act really fast. We have to know what it is and immediately start treatment. So a lot of these children, unfortunately, don't even make it to correct diagnosis and treatment, let alone a health facility, as we've seen in high burden settings with not very good access to care. And that leads to a lot of deaths. Unfortunately, the majority of the deaths that I mentioned, 230,000, were almost 80% are amongst children who are under 5, telling us that the mortality is really skewed towards them. So that makes it all the more an emergency to absolutely treat these children and to really get a grip among young children. Of course, it's important in adults as well, but this kind of makes it more of an absolute emergency. And the other thing is that unfortunately, TB that leaves a mark. Even when we are able to diagnose and treat it correctly, I have seen, and many of my other of my colleagues have seen children in whom TB has been treated correctly, but unfortunately, it has left behind devastated lungs. So these are children with poor lung reserves. Imagine like struggling to get oxygen. I mean, people can actually imagine this now in the times of COVID, when it is such a, it's all around us. So imagine being that way after you've had a disease endlessly. I mean, God forbid, that is like, a death, an early death full of complications. That's not a good way to live, unfortunately. It's like living with cystic fibrosis. So, and we see many kids like that in whom TB was perhaps diagnosed a little late and they have ravaged lungs. So you can have that. You can have children who have neurological devastation because of TB meningitis or tuberculomas. A child that was playing a month before and has ended up, unfortunately, with has ended up unfortunately with a condition in a wheelchair, was not even able to hold his neck up. Children can end up with disabilities, unfortunately, that they weren't born with, but they were, they can have an abnormal spine, they can have, they're unable to walk, they haven't even entered adulthood and they can't even walk, and they've got these, joints that are affected by TB. So to me, all of this, if this is preventable and it's happening, it just is, it is an abject emergency, and it's something that we need to do. We need to end.
Yeah. Thank you, Farhana. And it's indeed, like when you speak these things, I am so outraged, because it's true that for many years before 2011, TB in children was forgotten, okay? And there was this very wrong approach in the TB response before those years, in which, because it was assumed that kids are not infecting others, they can be out of the reported data and out of the programs. And I'm really grateful that we were past that times. And I know that, as you said, in 2011, rather late, but it happens, WHO started reporting the data. And this year as well, and I want to thank Teresa and her team, we also have the data for children with MDR-TB. But this neglect is still there, because not everywhere people realize how important it is. And to have children in this situation, as you describe, is really outrageous, because TB is curable and TB is preventable, as you say. So it's like, this is the kids with TB, especially the young ones, are a perfect victim. They are infected by an adult, okay? Their forms can go very, as you said, brutal. And 80% of the kids below 5 that are having TB, 80% of the deaths of children in TB are as you said, in kids below 5. So they are also the ones very difficult to reach the services and having access and so on. So we need to, and you see now with COVID, everyone is now aware of breath, airborne, wearing a mask, You see the difference between TB and COVID is that actually kids can be infected with TB, that's the first thing. Yes. And then they are getting sick and they are dying. Yes. So did you see, now how did, I know you are practicing and you are doing amazing work in Pakistan. So how did TB and COVID in kids, did you see anything? How did parents react on children with TB in this year? And did they still come to the clinic? Are they worried that it might be something else? Did you see anything in your practice this year?
So unfortunately, COVID has been a major deterrent, in fact, in children reaching diagnosis. So I think several high burden countries have reported that because of COVID, because of lockdowns, and because of services having been pulled back, we reported fewer almost a 60% drop in our routine, quarterly notifications happened. So that is significant. I mean, that means all those children that are requiring care weren't getting it, weren't reaching it, weren't getting diagnosed and put on treatment. And so we saw that for sure. And we had other countries also shared similar data. And so it was interesting that people were more concerned about catching COVID. I mean, so our I guess the way we counsel people and our program works so well that people are fine with, okay, yeah, I think I may have TB, but they don't want to be checked for COVID. They were like, literally like, okay, do we really have to get tested for COVID? We're like, yes, please get it done. So we saw some of that also, that people were reluctant to get. Yes, a definite significant drop in our preventive therapy access, people coming back for follow-up, people were lost to follow-up. There was also once the services were reinstituted to, although we never shut down our TB clinics, that was fortunate. But what happened was that a lot of the TB care was healthcare providers were sort of they were redistributed to doing some of the COVID work, which was also a bit of a tussle. And then they were, some got COVID also. So there were some people who were out sick, and so the services, there was definite service disruption. What helped, and what we have seen also help in Brazil, which was particularly hit hard with COVID, was how they were able to sort of leverage the TB services and use them for COVID, and also COVID experiences and use them for TB. So indeed, getting the right PPE, getting communities involved, multi-dose, the prescribing, giving people like 2-month supply as opposed to, like a 3-week supply or 1-month supply, those kinds of things. And so those things, so they really used COVID as an opportunity, we've seen some fantastic examples of that as well. So it's not all doom and gloom. We do realize that unfortunately a lot of a significant amount of the success and the momentum we built after the high-level meeting and getting people to reach targets and all of those things were unfortunately they hit an obstacle, and a lot of that success was also reversed. But I'm hoping that we will, inshallah, as they say, catch up and sort of reverse some of those losses in the coming months.
Yeah. So thank you, Farhana, very much. So this was like for us in TB, where we were really having a bit of wind in our, boats, so pushing us ahead. The COVID really didn't help. And with children on top of this, because, for people that are joining us and probably are not aware, we are doing this here just to make people aware. Not only that we have 7 kids a day dying because of tuberculosis. Okay, let's make that very clear. And, nobody, how many?
700 almost. Yes. So 650 plus. I mean, if you kind of split the 230 over 1,000 over a year, and a child every 2 minutes. So yes. I mean, just put it into perspective.
So you see, Farhana, that's what drives me nuts on one way, is because you see on COVID, we have all these graphs. Wherever television channel you open, wherever you go, for the respective country and global, you are measuring how many people with COVID per age group, gender, city are sick per day, and unfortunately die. And that's a reality, and it's a bad one. I would advise to put a same metric and the same type of information on TB as well. There are 4,000 people dying a day of TB, and 700 of them are children. And in spite of that, I don't see the same outrage. You don't see the same outrage. We are a handful of people that are really frustrated because it's a crime, but very few are even aware of what it means and what it happens. And very few are aware how difficult it is to diagnose TB in children because we don't have the right tools. And thanks God we have, and inshallah, that we have now some good formulation for children, child-friendly, for drug-sensitive TB, for drug-resistant TB. And here I want to thank very much the government of Japan, who really helped us to push child-friendly formulation for drug-resistant TB children, because till now, can you say a little bit how we used to treat the people with crushing pills, the kids, and also how is the diagnosis for TB in children happening?
Okay, so diagnosis in TB of TB in children, unfortunately, still we are behind, in the sense that we don't have a point of care test. We don't have a test that is not sputum based. We can't. I mean, we are still relying very heavily on symptoms, on chest X-rays, on imaging, on other, just sort of creating a case for TB in a patient to diagnose them, because the problem and the main problem with children is the fact that they are paucibacillary, which means that the smaller children don't have enough bacilli for them to test positive, and they don't produce sputum spontaneously, which means that if you can't cough up sputum, that is all of the testing is sputum based. But we do have stool for gene expert testing now, which is, again, because children are paucibacillary, the yield is also not, it's not 100%. It's still rather low. So that leads to diagnosis, like absolute bacteriologic confirmatory diagnosis being difficult in children still. Having said that, we are still able to do symptom screens in children, and that paired with say a chest X-ray and the history of exposure is honestly enough to make a diagnosis in children. It's not, you don't have to say, oh, I can't do this. There is so much that, there is really isn't this big, black box, or this, it's not, it is, you can make a diagnosis based on symptoms and on the limited tools that we have, the existing tools that we have. Of course, for drug-resistant TB, it's a little harder because we would like to see bacteriologic confirmation. We would like to see, drug sensitivity testing. We would like to see culture results, and we would like to see it under ideal circumstances. But even having said that, the guidance says that you can, in a child who is exposed to someone with drug-resistant TB at home and has symptoms, presume that it is drug-resistant TB, and even without confirmation, go ahead and start treating them. So your question was, how did we used to treat it? Till very recently, it was really an unpleasant and a very difficult road journey for a small child, say a 5-year-old, for 6 months of injectable drugs, multiple pills, up to 6 different drugs, and those 2 adult formulations, bitter pills that you had to crush and you had to resuspend, and they would still taste horrid, and the child would absolutely not want to take them. And imagine, this malnourished child with barely any muscle mass getting an injection every single day, and then having to suffer through the side effects of losing their hearing when they haven't even fully developed their language. I mean, it was horrible, and it still is in certain parts of the world where we haven't quite gotten with our newer formulations. And then this lasted for a good 18 to 24 months. So this was like, and you would lose patients in the middle, you would lose the families, they would just say, okay, enough, we can't keep doing this. Even in the best supported and very well developed programs, we had these problems. So it's been crazy. So thank God for the new formulations, for GDF providing us with these new formulations. I think it's a world apart now. I mean, having children are much better. Outcomes are better. We don't have to worry about hearing, which is so I think it is it's a huge deal for a small child to lose their hearing. Of course, it's a problem with a much bigger deal.
Yeah, we lose you, Farhana. And I will, while we wait for you to come back on online.
Got eliminated. Then there are places where people wear children for months and months. Hopefully, those things are also going to, take a step back.
Yeah. So, Farhana, I think we lost you, but I will go ahead with 2 points. One is we have 2 questions here. One is I can answer because it's from our colleague Ibrahim Mangi. It says if there are any specific grants for pediatric TB. And we have grants for pediatric TB. We had from GDF grants for medicines specifically, especially because of the support of the Japanese government. We were able to provide grants as drugs for treatment of drug-resistant TB to several countries, to multiple countries, and in this way we introduced this child-friendly drug-resistant TB formulation in 61 countries over a year and a bit. I think is the speediest introduction of a new combination in the world in 1 year. And thank you, our team from Stop TB, GDF, but also to our donor from Japan. But in addition to this, I will ask my colleague Ibrahim Mangi to reach out to us in Stop TB separately, because we have different types of grants going ahead. There is a submission and there is a process of reviewing the grants and funding, but there are opportunities to provide grants for pediatric TB. And we actually hope that with this campaign over the next months with Hello Kitty to get attention of donors of the huge amounts of funding that is needed for pediatric. Farhana, we have a question from Dubai, which is about the latent TB. And the question is if the children below 5 that are contacts of active TB without symptoms, which is the latest recommendation, to be tested and treated for LTBI or go directly to treatment? And yeah, so if you can go ahead with that.
Sure. So if you have a child who's under 5 years of age and is in contact with TB at home, and so it's important to know what kind of TB it is. If it is drug sensitive, if the person with TB at home has a drug sensitive strain, then the treatment obviously changes. So the current recommendations are that, of course, you can do the 6 months of isoniazid. Of course, and your first part of the question was that do we test them? It's a good idea to test the child to make sure the child does not have active TB, especially if you're in a good resource setting. You should check the child for symptoms, make sure they have a clear chest X-ray, and the child is healthy and thriving, which essentially means that they do not have TB. You don't have to go in and start, doing tests for gastric aspirates and all of that. If the child is well and has a normal chest X-ray, you can go ahead and start them on. You do not have to necessarily do a tuberculin skin test or an IGRA to define latent TB or TB infection. That is not required. As long as you know that there is no sign of active TB, you can go ahead and start them on either 6 months of isoniazid daily, or you can do 3 HP. So for a small child under 2, this is not 3 HP is not. This has to be if the child is over 2 years of age. You can actually go with 12 doses of isoniazid and rifapentine, or you can. And for the smaller child, it's either 6 months of isoniazid or 3 months of rifampicin and isoniazid, which is the combination pill that you would give in a child for continuation phase of the treatment anyway. So it's a pill that we already have formulated. It's water dispersible, easy to take, and it's again 3 months as opposed to 6 months. Of course, there's the 1 HP as well, which is again for children older than 2, but that is not a part of the thing yet. But 3 HP for older kids, and 3 months of RH or 6 months of isoniazid. And then if it exposure is to a resistant patient, then there is a slightly different protocol for that.
Yeah. So the bottom line on that is that children that are contacts of people with TB need to be checked up. Ideally,
Yes.
need to screen out the disease, because the worst thing is the kid is sick with disease and you give him this lighter treatment, to say so, and they need to be treated. So thank you so much, Farhana, for that. So we are heading towards our last point, which is, so as I said, me and Farhana will come in this space again later in December. We want to use as much this partnership we have with Hello Kitty to continue to raise awareness around TB in children, because everything counts. What we look the most is political commitment and funding, because we, for a long time, this neglect came from the fact that we had all the time to prioritize, and people were like, okay, children are not spreading the disease, so let's deprioritize them. So we need the money, we need the attention. We will invite mothers and children here, but Farhana, looking forward, if you would have a magic wand, what would you change like now? And, but also more realistically, looking at our UNHLM targets, what would you like us to do? So I want you to go a bit on the realistic targets, UNHLM, but also on the, we are here speaking about kids, we all believe in magic. So can we maybe dream of what we can do if we had a bit of magic? And that's my last question to you.
Okay, what a wonderful question. And yeah, yeah, magic is associated with children, isn't it? So I think for the realistic targets, reaching the UNHLM targets, unfortunately, we are, as you well know, that we are not on track for reaching them. I mean, we are still lagging behind, and with COVID and everything, things are going to backtrack further. I think, again, even my realistic targets might not be that realistic. I think if we had universal health coverage, free care, everyone at the front line knowing what TB in children looks like, or at least suspecting it, having the capacity to give preventive therapy, and even it can be given at the front lines, it can be given at the community level as well. Being able to do that, and referring or being able to refer a child to services that are close to home, that provide close to the patient or the child's home, that provide TB care, follow-up, and all the supportive care that goes along with it. I think that's really important. We have to think of the whole family. The child is not alone. He is associated with this group of people that live with him. You have to look at the convenience of the family, of the patient. This is a longer treatment, and it requires family support and whatever we can do for them. So again, reaching the UNHLM targets, I think it'll be very hard to do so without having free, access to free quality care, ideally through universal, health, through UHC. And just frontline workers, even say a person sitting in an adult TB clinic, should know that, okay, this is a young woman with 3 kids under 5, he should, and I'm treating her for TB, he should know what to do for those 3 children that are in tow with that woman. So this is how this is the only way we can really capture and make sure no child dies of TB. I think for your next part, and of course, I haven't even talked about the drug-resistant TB and all of that. I mean, of course, I could go on and on. I think I'll quickly come to the magic part, which is really like, fascinating. And I wish, I have a 9-year-old, so she's still into, magic wands and tricks and whatnot. So I wish I could magic up. I think the first thing I would do is find a point of care test, which is sensitive, specific, not sputum based, and give me an answer right now if this child has TB or not. I mean, that would be perfect, and that can be used at the community level. That can be used anywhere, like those lovely thermometers that we have now everywhere because of COVID. I mean, it should tell you like, okay, this is TB or not. That would be the ideal. And then if we could have a much shorter, simpler. I mean, it's fantastic the progress we've made recently with drugs, but to have the simple 1-week regimen like we would treat a sore throat, that would be fantastic, wouldn't it? And then we wouldn't need all that funding that we keep asking for. Oh my God, this is a 6-month treatment. We need so much support. We need special supportive measures for the children, for adolescents, and differentiated levels of care, blah, blah, blah. So then the requirements would also go down if I was able to magic up this fantastic regimen. But yes, yeah. I mean, reaching the targets would require funding, and political will. And I would say donors, we need separate streams of funding for children, honestly. I mean, we are always having to struggle and kind of like, please, can we have, but they're such a small proportion of the total TB burden and but we need specific funding for children, for R&D, for getting my magical wishes eventually.
Yes. So I have to say, Farhana, that this was, for me at least, the last part became very emotional, because to have a pediatrician like you working very hard in Pakistan, leading the entire global working group on childhood TB and adolescent, and saying that your magic wish is to have a point of care for the kids, which in this age of 2020, we have difficulties to diagnose, and we have 700 of them dying of TB every year, with the lack of attention and the lack of will, is what I find it absolutely unacceptable. So I will continue this push, as I know you do, because we are not doing it for us. We all have kids, yours are younger, so for them, Hello Kitty is attractive. My son was like, oh yeah, that's cool. And that was his only reaction. But I am pleading to all of us. We are few of us online. We will see, there will be others more on YouTube, and we will continue this. Please keep in mind that it's not just COVID that kills us, that there is a disease that it's also airborne, exactly like COVID, that actually children are getting it and children are dying of it. And this disease, it's also preventable, curable, very cheap, and we know it for a long time, and that is tuberculosis. So I was here with Farhana. I am very grateful, Farhana, for the time. We will continue doing this, and we will continue spreading the word. And thank you so much.
Thank you, Lucica. It's a pleasure.
Thank you. Thank you.